Welcome to the IAPB iHealth and COVID-19 web series. In this web series, we have invited experts from across different areas of health and development to discuss key topics that are impacting the sector during the current pandemic. Today's interview is part of a series of discussions to understand the way iHealth organizations are responding to the challenges in operating during the pandemic and adjusting to the new normal. Thank you all for joining us today. I'm delighted to be joined by Mr. Albert Kombo, Regional Director for Africa of the East and South region for CBM International. Albert is a seasoned leader with a demonstrated history spanning over 19 years working in the non-profit organization management industry. Since 2018, as the Regional Director for CBM, Albert has been supporting disability inclusion programs in 12 countries of the African continent. Albert has a keen interest in inclusive development, particularly for delivery of health, livelihood, and social protection, and has provided consultancy services to a range of organizations, including UNICEF, the International Labour Organization, the Global Fund, and the East Africa Community. Welcome, Albert. We're delighted to have you with us.
Thank you.
In our recent webinar with Ambassador Aubrey Webson, he mentioned that one of the key behavioral advice given around the pandemic is to sneeze into your elbow, which seems sensible to most. However, holding a person's elbow is key to a person with visual impairment. This is one example of how the pandemic is affecting people with disabilities. From your work, what are the additional impacts or effects the pandemic is having on people with disabilities?
Thank you very much for your question and the context that you presented. It is very true that most of the interventions that are being promoted for the general public tend not to include people with disabilities. And you've mentioned just one, sneezing into your elbow. So the question we ask ourselves is, assuming you don't have upper limbs, what do you sneeze into? And this is where we start by excluding people with disabilities. And it's not limited to just limbs. We are talking about messages moving around or being shared around. You want to ask yourself, if it's someone who has a hearing impairment, how do they get to know that someone needs to sneeze into an elbow? You are talking about issues such as social distancing. How do you implement that for someone who is visually impaired and relies on a guide for that matter? So some of the interventions that we are being proposed are good in theory, but they significantly exclude people with disabilities. And depending on the nature of disability, we find in exclusion having different effects from urban to rural areas, be it on mobility, be it on access to services like health, be it on access to livelihoods. For example, there are people with disabilities that are supposed to keep social distance, yet they rely on small petty trade along the streets of major towns. How do they reach those places? How do they keep distance? Yes, they still have to sell sweets. How do they get even the messages that are being shared around? So it's a major issue, and we need to do a lot to make sure that we don't leave anyone behind, including people with disabilities. And as I've said, the various types of disabilities present variously, and when you are implementing interventions, one has to put into consideration context. How we intervene in urban areas is very much different from how we intervene in rural areas, and how we intervene in situations where there are no crises is different from how we intervene in areas where people are in refugee camps. So all these are challenges and contexts that we need to deal with.
Thank you, Albert. Those are all very interesting points. I think that one of the broad issues of this particular pandemic is that it affects the individuals, but it also affects those around them. We all know how some of our behavior has had to change, particularly not necessarily to protect ourselves, but also just to protect those around us. How does this then impact the families of and the communities of those with disabilities?
Now, one of the things that we have to deal with, that we've been dealing with, is that disability is stigmatized in most of our settings. That is one. Now add that the stigma associated with COVID-19. This, in as much as it's not a disease that is supposed to occasion stigma, we've seen a lot of stigma associated with it. And in settings where we work, we find that families with people, with members who have disabilities are experiencing challenges, even not just being affected, but also being seen as people who have invited the condition amongst themselves because of a curse within the family. And I give examples from as far as South Sudan, where we are having challenges just having people with disabilities being accepted by the communities. And of course, stigma is not limited to the person with the disability, but with his or her family. We have those who are being, for lack of a better word, hidden or secluded so that others should not see them. And yet we are in a situation where access to livelihoods, access to basic sanitation, access to water and sanitation services is a challenge. So this is affecting not just the person with the disability, but also members of their family. Now, come to think about it, when these people get sick and they have what I would call double jeopardy, stigmatized for disability and also stigmatized for COVID, how should this person react then or respond to such a situation? Then you have cases where, for all of us, even people without disabilities, access to livelihood is significantly compromised, and we are relying on technology to do our work and to make sure that we continue providing for ourselves. But when it comes to people with disabilities, technology and their families, technology has not taken their needs into account. Yet, some of them, when we talk about people with disabilities, some of them are fathers, some of them are mothers. So even the setup that we find ourselves in, what we tend to call the new norm in terms of how we work, is excluding people with disabilities. Remember, interventions that are supposed to help us, to help cushion us, or to help us cope with the situation. When it comes to people with disabilities, you require a lot more time and understanding. So if you are training, if you want to reach such a family, then you must put into consideration their family members as well, who have to support them. So this is greatly affecting them. We have cases like in Rwanda, where we have people with disabilities who have been members of livelihoods or what you would ordinarily call savings and loan schemes. And we've been promoting interaction with people who are not with disabilities. So I'm talking about a community which is inclusive, where people with disabilities are not just considered as separate entities, but parts of communities and parts of families. So when they are stigmatized or discriminated against, this has a direct effect on their immediate family and has a direct effect on their communities. As I said earlier, our interventions in most countries, government-led interventions, tend not to focus on the minority, and people with disabilities and their families are part of the minority. So when this is happening, you are not just excluding that specific person, but the family that depends on it. So interventions must reach these people. We must move away from the notion that people with disabilities are always dependents. There are cases where they are the primary caregivers. They are the primary breadwinners. So when we cannot reach them with interventions, we are affecting not just them, but also those who depend on them, including their children. A classic example would be around education. Most countries are considering reopening schools. Most of these schools, some of the schools are inclusive. In other words, you're having people with disabilities as well as children who do not have disabilities. But the conditions required, having masks throughout, some of them have no capacity even to change masks on their own. They need someone to support them. So how do we reach their families to make sure that they are supported all the way from home to the school setting? So in essence, at a general level, by not including people with disabilities in our interventions, we are also discriminating against their immediate families, as well as some of the communities that rely on them. Yeah. So it's a challenge for us to have a different mindset in terms of how we design programs and how we make our interventions more accommodative, more comprehensive, and that they do not leave people behind. And remembering always that people with disabilities form part of the minority and they don't live alone. They have dependents as well. Yeah.
Thank you, Albert. That leads quite well into my next question, in fact. So this next statement is from the United Nations Secretary General, Antonio Guterres. He said, "We must guarantee the equal rights of people with disabilities to access healthcare and life-saving procedures during the pandemic." So my question to you is, practically, what should be included in responses to the pandemic to ensure a disability-inclusive response?
Thank you so much. We want to look at this we need to look at this from different angles. One, assuming that we start from the premise that people with disabilities are involved in gainful income generation, then what do we need to do in our response to accommodate the activities they find themselves in? And that starts from all the way, the messaging bit that I talked about. When we are passing messages on prevention, for example, how inclusive is the medium of communication? How inclusive is the medium of communication to make sure that people who cannot hear are reached, people who cannot see are reached, people who don't have access to certain media of communication are reached, be it in urban, rural, or other conflict settings where people with disabilities find themselves in. So looking at the broad area of prevention alone, there is the messaging bit that needs to be done. Then the next thing is when we talk about treatment, because they have health needs, how do we make sure that they continue to access their health services that they so desire? Remember, we are talking about rights here. And rights, from a rights perspective, programming from a rights perspective presupposes that access is guaranteed. It is available and it is affordable and it can be physically accessed. Now, within the context of COVID, what have we seen in some of the countries? Disability inclusion activities, even where they have been mainstreamed within governments, have been compromised. Resources, including personnel that are working in some of those departments, there have been attempts to move those towards general public COVID response without putting disability as a core area of focus. So even where we had gains, and I can give an example in a country like Kenya, some staff were moved from the department that is focusing on disability to other areas that, and the argument has been that COVID is an emergency. Yes, it's an emergency, but it's more of an emergency for people with disabilities and other vulnerable groups than any other category. So prevention, I've talked about prevention, I've talked about treatment as a key area. The next area, of course, we are talking about livelihoods. People have to continue making or surviving for that matter. How fast are our social protection or social security interventions that we are putting in place? They are not that fast in most countries, and where they are, for example, cash transfers, where cash transfers exist, it's a question of being few and far in between and not addressing all the needs. And in most cases, it is not appropriately targeted. It's generic in nature, and it doesn't reach the most vulnerable population. So if we are designing programs, we must make sure that we appropriately target people with disabilities and we disaggregate them clearly so that we have measures for reaching them well. I can say that people with disabilities have not been sufficiently reached with some of these social protection measures, like cash transfer. And some are still waiting in most of the countries that I know. Yes, the will is there, but the mechanisms are not sufficient. Then you are talking about general engagement with the communities. For example, access to water points. You look at the water points that are in place, they don't put into consideration the needs, special needs of people with disabilities. So even in terms of interactions with other people, you find with other members of the community, you find that people with disabilities are not provided for in interventions. So to respond in a generic sense to the comment by the Secretary General, I would say that we look at all the components of response, from prevention, treatment, mitigation, which includes the livelihoods and general interactions with other community members, and take into consideration the special needs of people with disabilities. And we must recognize that governments are not necessarily constituted to lead on every front, and working with entities or civil society organizations that have a special interest in these areas and that have demonstrated experience would really help us, would really move the process further and in a way that is effective insofar as reaching with people with disabilities is concerned. Yeah.
Thank you, Albert. And looking specifically at ICARE, what can ICARE organizations do to be disability inclusive during the pandemic?
Okay, so there are several angles, and the most important thing beyond sustaining service delivery is advocacy. Why do I say advocacy? I say advocacy because, one, we need to sustain the gains that we've made in all the countries in terms of magnifying ICARE as an issue. We need to defend the resources that have been allocated to ICARE, or that have been earmarked for ICARE. And this we can only do through advocacy by coming together. So civil society organizations need to come together and engage with the government in a constructive manner so that we defend the gains that we've made so far. At another level with the advocacy, we also need to demand for more so that there is appropriate and responsive targeting of people with disabilities. It is one thing to defend the gains made, but it's another thing to expand that space by making sure that our responses are as inclusive and accommodative as possible. So that for me is the major thing. But then below that, civil society organizations need to continue with what they have been doing in terms of service provision. They are supporting partners, local community organizations for service provision. This has to continue and has to be expanded. Civil society organizations need to do a little, increase their allocations or resources so that they can support people with disabilities to go to facilities and access services that they need. And it is even more important to target hard to reach areas that are often forgotten. And when I say hard to reach areas, I mean those remote areas, other than urban settings, that sometimes tend to attract greater attention in times of crisis like COVID. So maintaining advocacy and sustaining our work by coming together would really be helpful. And another, of course, very important thing is to document lessons. We need to ask ourselves, since this crisis started, did we react in the right way and at the right time? Were we slow to react? Were we resilient enough? And if not, were we trying to do, have we been focusing on what we are strong at, or are we trying to be all over without necessarily specializing in what we have, what we can do better? So there are questions about civil society on the part of civil society organizations, because I think we did not respond as fast as necessary to this by creating the necessary framework that would allow us first to defend the gains we've made in the area of disability inclusion, especially insofar as ICARE is concerned, but also expanding that to make sure that people who need ICARE services and have disabilities do so in a manner that is efficient and effective.
Thank you, Albert. Albert, you've spoken of coming together
Yes.
and working with others. Are there key organizations or coalitions which IAPB members could work with to both give their expertise around blindness and vision impairment, and also to improve their practices around disability more widely?
So the question that is a very important question. And what comes to my mind is, where is it that we want to see success? Do you want to see success at a global level only, or do you want to see success at the grassroots? So the answer to those questions is that we want to see success at all levels. At the global level, to expand the gains made so far, but also at the grassroots levels, so that we can deliver more efficiently and more sustainably. So at a global level, I think there are the organizations that currently constitute the membership of IAPB seem to be doing a good job. But we should ask ourselves whether integration could help. And when I say integration, are there like-minded entities that will have one foot in disability, and specifically eye care, and other feet elsewhere? Those are the ones we could target. Those that tend to implement opportunistic interventions in the area of eye care. And I could mention organizations, for example, in this region, like AMREF, African Medical and Research Foundation. I'm not sure whether it's a member, but this is an organization that we could probably bring on board, because they are addressing issues such as trachoma in certain areas. But that is at a global level. At the community level, there are so many strong local organizations that are resilient, and which we need to support and engage for better learning in terms of what works on the ground and what can be strengthened. So I think IAPB by nature is more global, high level, but maybe we need to ask ourselves whether there are national and local organizations that we could bring on board. And I think there are so many, especially those that have expertise on service provision, as well as inclusion.
Albert, I'd like to thank you for joining us today. And I'd also like to thank all of those in our audience who joined us as well. We do hope that you found this useful. And as I previously mentioned, we have more interviews and recorded webinars available to view as part of the COVID-19 and eye health series that are available on our website and social media channels for you to view. You can also find further upcoming webinars, articles, and resources in our COVID-19 resources page on the IAPB website. Thank you all for your time today. Goodbye.